ideas. It's been the ability to translate those ideas into real-world impact. I think that is exactly where Texas Health Catalyst plays a critical role. The program reflects how we approach innovation at Dell Medical School and across UT Austin. It's by design intended to bring together clinicians, scientists, engineers, entrepreneurs, and really creating pathways that allow ideas to move from discovery to delivery. I think the results are impressive. More than 80 early stage innovations supported, nearly 40 companies launched, over $100 million in follow-on funding. I think what matters more than these numbers is what it represents. I think it suggests and underscores a system that is starting to work differently, and a pipeline that can connect insight to implementation with a growing capacity to translate innovation into improved health. That direction is deeply aligned with where we are headed at UT Dell Medicine, UT Dell Medical Center, as we build toward the medical center. We are not simply expanding a health system. By definition, we seek to design a fundamentally different model for health, and a model that you've heard me say, some of you, that it is AI native from the start. And it's important to understand what that means. It doesn't mean we're taking AI and layering it on top of an already broken system or workflow or health enterprise, but one where we think about AI being embedded into the foundation of how care is delivered, patient-centered, human-connected. And importantly, how we will use that to help inform our decisions, how to create a system that continuously learns, and importantly, thinking of how such a system can help us move from what we really see as fragmented episodic care, which are snapshots of health, often with the burden transmitted to patients and their families with disconnection, to continuous real-time understanding. And the idea of really how can we move from reactive care, which is what we have today, to predictive and preventative care. And also, how do we move from one size fits all to more personalized care? And importantly, to allow us to connect clinical care, research, and innovation into a true learning health system, where every patient interaction improves the next. Our vision goes even further. At UT Dell Medical Center, we are also leaning into what we think of in the space of healthgevity, meaning not just thinking about sick care, but how do we not just extend the lifespan, but the health span to lead healthier, better lives. And in this space, we really are focused also on how do you maintain cognitive, physical, metabolic health over time? How do we intervene earlier, long before disease becomes irreversible? That does require new tools, new data streams, new models of care. It requires really thinking in a team-based way and in an interdisciplinary, transdisciplinary way with diagnostics, AI, behavioral science, implementation science, continuous monitoring, engineering, et cetera, into a cohesive system. I just want to acknowledge that this vision in part is being made possible also by the extraordinary investment of Michael and Susan Dell. I think it's important to recognize that that gift is not just philanthropic, it's catalytic. It allows us to build an entirely new kind of infrastructure, one that we think about integrating care delivery with data, technology, and innovation from the ground up, one where we don't have to retrofit, but build in as foundational layers. And it's also important to think about how the system we're building is intended to be designed to partner with the Austin ecosystem. It's startups, it's engineers, it's investors, to accelerate how new ideas are developed, tested, and scaled. And ultimately, it's to position Austin and Texas more broadly as a leader in defining the future of health, as a model of health for the country. You can already see, I think, signals of that future in the work being presented today, from liquid biopsies enabling early cancer detection, to accessible diagnostic platforms, to new approaches to brain health, aging, and continuous monitoring. It is these kind of innovations that in an AI native system can be more readily integrated, scaled, and translated into real impact. And I'm especially encouraged by the focus on dementia, neurodegeneration, and brain health. As a neurologist myself, I see how urgent these challenges are and how much opportunity there is to rethink detection, monitoring, intervention, treatment in entirely new ways. None of this happens without leadership and intentional design, and that is what Texas Health Catalyst represents. Which then brings me to Ruben. Ruben has been instrumental in building this program and shaping the innovation ecosystem at Dell Medical School. Over the past decade, he has helped create a model that connects disciplines, supports innovators, and enables real transition from discovery to impact. And now he is stepping into a new role as the inaugural executive director of the Zhenwan Huang and Lori Mills Huang Collaborative Innovation Complex at Oregon State University. That next chapter is especially fitting. The complex is focused on building a new model for AI-accelerated transdisciplinary research at scale that is very much aligned with the direction we are pursuing here. While we will miss Ruben and Austin, this is also a reflection of the strength and relevance of what he has built, and that the work here is not only enduring, it is helping shape how the next generation of innovation ecosystems are designed. And importantly, this creates an opportunity, not an endpoint. An opportunity to build new collaborations at the intersection of AI, technology, and health, connecting UT Austin, UT Dell Medical Center, Oregon State, and partners across the country. So I want to thank Ruben for your vision, your leadership, for helping build something that will continue to shape the future of health both here and beyond. And with that, I will turn it back to our leader, Ruben.
Thank you, Claudia, for very exciting and for your generous words. Okay, now this is, as you guys know, my favorite part of the show. I want to take some time to acknowledge and thank the people who, many of you are here today, who contributed their time, their expertise, and their resources to the projects in this cycle. These are the folks who participated this time in reviewing the applications that came into the program and also mentored the teams. Every cycle they grow in number. Now we're almost 400 of them, and we pull from that 400 for specific cycles based on the applications we receive. So I just want to highlight a couple of people here. Hillary Graham. So when Hillary reviewed the proposals, she said, this is such a crazy idea, and there's so many challenges, but if it works, it's going to be amazing. And I want to help this team identify what the biggest risks are, and first understand what the risks are, and then address them. Next, Tim. I always look for the beautiful hair. You have in the ponytail today. Tim Sullivan. Longtime mentor, veteran device drug delivery expert here in Austin. When he saw the project that he mentored, not only did he want to help the team refine their strategy so that they would be more clinically and commercially viable, he also felt that the company he runs could potentially help translate and commercialize the technology if the data looks good. And then finally, someone from the inside. So Sri Chalikonda, don't see him here, our new Chief Clinical Transformation Officer and Vice Dean of Practice. He looked at his project and he said, this is so messy, it's going to be hard, but if they could make this work and add this extra piece, I would use this every day and it would be a game changer. And he wants to help them figure out how to add that extra piece and make it commercially viable. So, I have stories for each of these people, but I'm going to be kicked out in a couple of seconds, so I'll just stop there. But when you hear these folks who have more than full-time jobs get excited about these projects and now want to volunteer their time to help them, you can't help but be excited and proud of the Texas Health community. Right? And so thank you to all of you for doing that. And before I hand off, I also want to thank a couple of my team members who are also transitioning on. Chris Stefan, who is our longtime executive administrative assistant. Chris, thank you for everything that you do, and me personally helping to navigate the maze that is the UT financial system. Thank you for that. And also Praneet Saja, who is our lead health associate, who has been here for 3 years. He's actually going on to med school. And congratulations, Praneet, and I'm going to hand it off to Praneet. Thank you.
Thank you, Ruben, for that warm introduction. So I want to start off by talking about our incredible, one second, I might have clicked on the wrong slide. Okay, our incredible health associate program. It's unreal that this is my 4th cycle with them, and it's been amazing to just see this program grow over the years. We started off with I think, almost 100 students this time around with our bootcamp series, in which we educated these students about health commercialization topics like value proposition, customer discovery, and FDA regulatory pathways. And we selected like 25 of these incredible students to then work with the Texas Health Catalyst teams that you'll be seeing present today. And each of these students have been invaluable assets to their teams, helping them over the past month or so really develop and refine their products and pitches. And hopefully they'll be able to talk with you upstairs after the event today. They're really eager to learn. And it's just, please, round of applause for all of the students here with us today for their work. And while it's my last cycle, I know I'm going to be leaving it in great hands with my friend and colleague, Grace Wang, who will talk more about the Health Associate Program.
Thanks, Praneeth, for the introduction. If you are a current undergrad, graduate, or medical student interested in this amazing program, please scan this QR code and fill out the little form so we can remind you to apply for the next cycle in late August. And now I'll pass the mic over to Nicole Clark.
Okay, thank you, Praneeth and Grace, and thank you everyone again for coming here today. We're very excited. So I'm gonna go ahead and get the pitches started, which is what we're all really here for. To give a quick rundown of what's gonna happen, so we're gonna have each health associate come up, do a quick 60-second intro, sharing with you all what their experience was, what they contributed to the teams, and then they will bring their project team lead up to do a 3-minute pitch, which will then be followed by a 2-minute Q&A from our judges. They'll be judging on the award categories listed here on the screen, and then there will also be an opportunity for an audience choice award, so you'll be given the opportunity to vote after each of the cohorts. Okay, so group one, we've assigned 4 judges to be the ones scoring for this group. We have Mike Yost from Discovery to Impact at UT, Max Dordovec from NeuroX1, Alex LeBeau from Tatum Biosciences, and Salim Sayed from Dell Medical School. Yeah, woo! Okay, so then without further ado, I'll go ahead and introduce our first health associate who will be presenting, Sophia Pryor. And Chris Mai, sorry.
Hi, my name is Sophia Pryor, and I'll be speaking on behalf of my fellow Texas Health Associates, Chris Mai and Aaron Belani. This semester, we had the opportunity to talk with Dr. Chan and learn all about her project on a new blood test designed to help detect liver cancer earlier. As a health associate, our main job was to perform market research, in which we assumed that our market was labs. However, thanks to our mentors, Dr. Crystal Brown, Gail Page, and Christian Becker, we were able to determine that the market was actually clinicians with patients that have chronic liver diseases. By creating our business model, we determined that a blood test for early detection of liver cancer can actually save both costs and lives. Working with Dr. Chan has taught us how important it is to tailor solutions to patients to doctors who care for their patients. And with that, it is my honor to introduce Dr. Chan and her project, Spice DX.
Thank you all for being here. I'm excited to announce our liquid biopsy approach to early liver cancer detection. SpliceDex is a collaboration between the labs of Georgia Coppola Suarez and Ahitub at UCSF. So there are more than 40,000 new cases of liver cancer every year. We know that early detection can double the survival odds, but there's 3 existing challenges. First, the current standard of practice, which is also ultrasound screening, only finds 63% of early stage tumors. On top of that, only 1 in 4 high-risk patients with cirrhosis actually go to their biannual ultrasound screens. And that's tied to the lack of accessibility, where almost half of these patients cite some kind of barrier to going to their ultrasound screens. So our goal is to close these gaps in sensitivity, adherence, and accessibility. Our solution is a liquid biopsy approach that's built around a technology we developed called splicemers. These are biomarkers derived from cancer-specific splice junctions that can be found in patient blood. So in our pilot cohort, we found that splicemers can detect early cancer at 75% sensitivity. So this is our proof of concept that we can find splicemers in patient blood and use it to detect early liver stage cancer. So our strategy is to work with clinicians to support the existing screening workflow. So we want to give a chance to the 3 out of 4 cirrhosis patients that couldn't make it to their ultrasound appointment, but they could go to have their blood taken. So we think that with improved adherence, we could push this detection earlier for more than 3,000 patients. So why is this commercially actionable? If you look on the upper left-hand side, you can see the cost of Medicare payments in the first year after diagnosis. When you diagnose at an early stage, you can have the cost of these Medicare payments per patient. So our strategy is to have a broader reach and a strong reimbursement case by shifting care away from late-stage, high-risk, high-cost treatments. Our core value is in our splicemer biomarkers, as well as our classification algorithm. Finally, we'd like to work with existing lab networks that already have established capabilities, established networks to run our assays. They'd be able to take our splicemer biomarkers and algorithm, run it as a targeted panel, and finally return a risk score back to the clinicians. We're asking Texas Health Catalyst for non-dilutive funding to expand our validation cohort. We'd like to make SpliceDex more generalizable and robust. After that, we'd like to work with clinicians and testing sites to move this proof of concept into the clinic. So with that, I'd like to thank you all for coming, and if any of this speaks to your network or your expertise, I'm happy to connect. Thank you.
Okay, so now we can open it up to the judges if you have any questions for the couple of minutes we have allotted.
Thank you. Very great presentation. So is there any competition to your technology?
There's competition, well, I won't name them, but there's other cell-free DNA companies out there. We have an advantage in that we don't need special sequencing platforms like methylation, etc. These splicemer biomarkers are just short sequences that you can have. If there's a low enough number, you could even do digital PCR to find them. And that's much cheaper than any of these other companies' technologies.
Thank you.
Great, thanks, great presentation. Real quick, so this test is relevant for chronic liver disease patients. Can you define what that market looks like in US?
Sorry, could you repeat the last part?
This test is really targeted for chronic liver disease patients, right? Have you looked at what that market looks like?
Have we looked at?
What's the number of patients you would be eligible to get screened?
Yes,
It's widely available.
there's at least, I think, 600,000 in the United States alone with chronic liver disease, and that number is expected to rise because it's correlated with obesity and alcohol misuse. So the 3,600 number, that's a conservative measure. We're estimating at least 60% adherence to these blood tests rather than 50%.
Okay. Would this be a yearly test or once and done?
Sorry?
Would this be a yearly test or once and done sort of?
So ultrasound screens are conducted biannually because liver cancer grows very quickly, and we'd expect the same for a liquid biopsy test.
Thank you.
Candace. Yeah. Okay, so next up, I will introduce Dustin Walters Iris Rafferty and Ishan Sheth to introduce the next project team.
Hello, I'm Dustin Walters, joined by my fellow health associates Ishan Seth and Iris Rafferty. And over the past few months, we've had the opportunity to work together with Babson Diagnostics and Dr. Malamed's lab. And we want to say we're incredibly grateful to our mentors, Dr. Lekha Gopalakrishnan and Stephanie Ibbotson, for their thoughtful guidance in strengthening our project's work, as well as the in-depth advice that they provided throughout the process. As health associates, we spent a lot of time on understanding capillary biomarkers and our innovation that our project was focused on. We supported our team through market research and strategic analysis, and we evaluated the competitive landscape, synthesized discussions between Dell, Babson, and our mentors, and asked targeted questions to clarify key decisions and refine the business strategy. Through this work, we've helped sharpen the project's focus and refine the strategy going forward. Now I'm excited to hand it over to Dr. McGuire to share more about the science and the vision behind the project.
Thank you, Dustin, for that lovely intro. So I'm going to start with kind of a scary thought. I want you to imagine yourself or your loved one with cognitive impairment. Now, for some of you, it might not be, hard to imagine having experience with that. However, what I want you to think of is there any length you wouldn't go to better understand the cause? Unfortunately, over 16 million Americans are diagnosed with cognitive impairments, leading to a total cost of over $264 billion. However, despite how common it is, we actually have a really tough time figuring out what the underlying cause is. And this is where this novel area of biomarkers, or small molecules in the blood that we measure, really help with diagnosis. Now, there's 3 biomarkers that are really hot right now, and that's going to be p-tau217, NFL, and IL-6. Now, all these biomarkers are typically measured with venous blood, which is your normal blood draw, which a lot of people don't like, but I'll tell you, cognitively impaired patients really don't like it. Additionally, this is actually kind of difficult in some areas because you need to train phlebotomists, which means that in areas with less healthcare, you might not be able to access it. The alternative is a capillary blood draw, which is a blood draw from your fingertip. Now, this is much easier for patients, and it's much more accessible as you can deploy these in pharmacies. And so our goal is to take these biomarkers and move them to a capillary blood system. Now, to do this, we assembled a super team of experts, which is a collaboration between both Dell Med as well as Babson Diagnostics, local here in Austin. From the Dell Med side, we bring the neurological expertise, the access to the patient population, as well as experiences with these biomarkers. And from Babson, well, their bread and butter is moving assays to capillary blood. This is what they do. And additionally, they have experience taking it all the way to market. So our solution is to bring together 2 proven systems, one Babson's capillary blood collection system, as well as existing market assays for these 3 markers. Now, the benefits of this is Babson has already done this with over 65 lab tests showing equivalency with the venous blood, and they've proven scalability. For the existing market assays, well, they're already being reimbursed by insurances, and there's only venifunction on the market. There's no capillary competitor. Throughout Texas Health Catalyst, we've gotten a lot of amazing feedback, and in response, we've established more strategic partnerships, and we've reinforced our approach to IP. However, I will say IP is not necessarily our initial goal for this project. Really, we're thinking about taking the Texas Health Catalyst funding and growing it into larger grant opportunities. Here's a quick view of the timeline. In the first 6 months, we'll focus on participant recruitment, and in the last 6 months, we'll conduct the biomarker analysis as well as prepare publications, and ultimately thinking about growing this Texas Health Catalyst funding into larger funding opportunities. So to end, I want to take us back to our why. As a patient with cognitive impairment, would you rather have one check-in or multiple check-ins where you can better understand the trajectory of your cognitive impairment? Additionally, thinking forward, there's opportunity for risk-based stratification of patients, as many of these biomarkers have new evidence saying they're high years in advance of cognitive impairment, and they're actively being used in clinical trials as new endpoints, as they're more sensitive to clinical symptoms. And with that, I'd be happy to answer any questions.
Any questions from the judges? Okay, well, it seems like, go ahead. I was gonna say you
So why hasn't this been done before? And if it has it failed? And why you? Because this seems something that
It seems so straightforward. You're like, why has no one done it? The simple answer is capillary blood draws are much trickier than you would think, and this is why we partnered with Babson, because they really are the experts of this. I actually have one right here. Because to do these blood draws, you really need the blood intact, right? Like the blood can disintegrate sometimes on draws, and if you do just a normal basic capillary blood draw that's unrefined, that will frequently happen, and that messes with the assay, and so it messes with the readout. And so really a lot of other people have struggled because they just don't have the technology for the blood draw itself, which is where I think we are better positioned to tackle that issue.
How much volume are you actually taking of blood?
Really not that much. It's variable, obviously, on how much you can get, but you know, like 0.2 milliliters to 0.5 milliliters, like it's a very small vial.
And can you extrapolate that out to other, like, you know, actually, before I ask that, who has the UT has the IP, Babson has the IP. How does the agreement with Babson work?
Great question. Here we have some simple bulleted points. We might have gotten told this is probably a question that's going to come up. But like both parties will own their pre-existing IP. However, any new IP that is joint will be handled jointly. So we are, long story short, I'm not an IP expert, I'm a scientist. I try to involve the IP office to coordinate this. It is in the works and we have more fine-tune agreement. So hopefully that answers your question.
And then can you extrapolate it out to more, like do you have future sort of biomarkers in the pipeline?
We do. I mean, like, so we pitched 3 because we believe we can do 3 off the funding of Texas Health Catalyst, but the long-term goal is to do additional ones and really think about more signatures, et cetera. However, for reimbursement purposes, one of our mentors said you really should keep everything as single analytes because that's what insurance companies like, but we are thinking that direction long-term.
Thank you, Cole. Okay, next up, Health Associates Ryan Sani, Nicole Wu, and Anjali Chabra.
Good afternoon, everyone. Thanks for the introduction, Nicole. My name is Ryan Sani, and along with my fellow health associates Anjali Chabra and Nicole Wu, who's supporting our team remotely today, we've had the privilege of working with the InhaleDX team through this Texas Health Catalyst cycle. Our primary focus has been bridging the gap between Dr. Chen Zheng's innovative research and a viable clinical application. Specifically, we analyzed the current diagnostic journey for patients with pulmonary fibrosis and interstitial lung disease to identify where InhaleDX can reduce the time between diagnosis and treatment. Furthermore, our team quantified the potential cost savings for patients by highlighting how this tool can reduce reliance on invasive and time-consuming diagnostic procedures that currently exist. We've gained incredible insight into the bench to business to bedside process through the Catalyst boot camps, and we want to give a huge thank you to our mentors, Dr. Tim Sullivan, Dr. Hillary Graham, and Dr. Mohammed Al-Sumrain. And we're confident that InhaleDX will redefine the accessibility of pulmonary fibrosis care. To walk you through the technology itself, it is my pleasure to introduce you to our project lead, Dr. Chen Zheng.
Hi. Thanks for the introduction. I'm happy to introduce our biosensor platform, InhaleDX, that supports the non-invasive diagnosis of pulmonary fibrosis. This is a non-traditional liquid biopsy platform. So PF is a lung disease where it's deadly lung disease where lungs get scarred and stiff, and eventually the patient is not able to breathe and die from that. So standard diagnosis of pulmonary fibrosis starts with the CT imaging, but it often requires the surgical biopsy or bronchoscopy to confirm the disease. Think about taking out a piece of lung tissue and figure out what's going on. It sounds like scary. So, but our InhaleDX platform is designed to fully bypass the invasive procedure and work along with the CT or as a standalone test to identify fibrosis in the patient. So InhaleDX is not a traditional liquid biopsy platform. It comprises different modular components, so including a panel of biosensor that target abnormal enzymes in the disease. So once the sensors are inhaled, enzyme will metabolize the biosensor, generating the biological analyze within 2 hours. And these analyses can be measured through a point-of-care urine test within 2 hours. So our goal is to make the single test cost less than $200. In the past few years, we have extensively tested the InHealDex platform in many lung disease models, in preclinical models. So the InHealDex demonstrates high specificity and sensitivity towards the fibrosis, indicating it has the potential to accurately identify who truly has disease and who, while minimizing false alarm. We have assembled a talented, competent team to advance the technology. So my research team has extensive expertise in identifying enzyme targets in the disease and refining the design of the biosensor. So my academic collaborator focus on how to get the sensor efficiently into the lung and validate the sensor in preclinical and humanized models. So I'm also collaborating with many clinicians to collect patient samples to validate the biosensor in the human samples. Lastly, we also identify potential corporate partners that can help us customize the device for the InHealDex. So over the past few weeks, we have come up with our health with our mentors, come up with a plan to redefine the human feasibility and usability for the index, and also understand, clarify the regulatory pathway for the index to the market. So our path to the market is we will keep systemically evaluating the technology in the lab. In about 2 years, we hope to spin out to have a startup company and eventually license the technology. So by the end of the THC program, we hope to complete the pilot toxicity evaluation in the preclinical model and pilot validation on the clinical samples. So, and then in long term, we hope to bring this technology to the chronic other lung disease and also lung cancer screening program. I'm happy to answer any question. Thank you.
Thank you, great presentation. So could you also maybe elaborate a bit on the possibility of this technology to be bundled with other commercialized biomarker to increase the specificity and therefore looking for higher reimbursement?
Yeah, so the current liquid biopsy platform basically looking at the expression of endogenous biomarkers, but none of them is specific to the pulmonary fibrosis, also confused with other interstitial disease or lung cancer. But our technology basically measure the functional biomarker, which is enzyme activity. So pulmonary fibrosis is specifically associated with the signature of a proteolytic signature. And then our sensors are able to capture this signature to increase the specificity. And then on the other ways, we're not only targeting one specific enzyme, we're actually targeting multiple enzymes, up to 20 to 30 enzymes, and then eventually generate a signature in the urine. In combination with a machine learning algorithm, we're able to recognize the pattern that can be tied to the pulmonary fibrosis. So in a larger picture, so each disease is associated with the enzyme signature, so our sensor are able to capture the sensor. So, and then eventually couple the disease with the urinary signature pattern. Yeah, so that's a way to increase the specificity and sensitivity.
Okay, I think that's it from our judges, so we can wrap up. Okay, so we have one more team as part of this cohort, so I will go ahead and bring up Leslie Mejia, Anthony Lopez, and Andrew Kulkarni.
Good afternoon, everyone. My name is Leslie Mejia, and this spring I had the opportunity of working alongside my fellow health associates, Andrew and Anthony. Together, we helped support an amazing team led by Jordan Tanny, working on Drain Plus, an adhesive portable surgical drain module. As health associates, we really focus on understanding the health market, as well as helping the team really refine their idea to truly connect it with the patients and physicians it serves. Additionally, we helped foster communication between our mentors, Elisa Maldonado, Dr. Eker, and Dr. Chalikanda. Overall, we truly see the impact that this device could have on the future of healthcare, and we truly hope that you see that potential as well. Without further ado, I'd like to introduce Jordan, who will be presenting on behalf of the team.
Thank you, Leslie, for the kind introduction. My name is Jordan. I'm a medical student at the Dell Medical School, and I will be presenting Drain Plus here on behalf of my team, who are all in the room. And I'm going to go ahead and start. If you think of any 8 women that you know of right now, statistically in the United States, at least one of them will develop invasive breast cancer. About half of those will require a mastectomy of some sort, and that all but guarantees you're gonna have a surgical drain. Jane here had 6 of them. Those are 6 different opportunities for her to develop a seroma or a surgical site infection due to a clog within the system. Clogs happen for a quarter of drains. She's gonna have those and deal with them for 2 to 3 weeks on average. And this problem isn't unique to just surgical oncology. The opportunity that we're presenting here is with the problem being that drain obstruction produces stagnation in fluid, and the drainage being obstructed will increase the dwell time, postoperative infection risk, and reoperation risk. On average, these complications cost about $4,000. And the solution that we're presenting at scale for 10,000 patients at just 40% efficiency can generate a 10x return on investment. Currently, when a drain is placed, it's managed manually by stripping the tube or by involving the healthcare team like nurses and other clinicians. And what we're proposing is a world where drains don't require as much manual input and enhances their function and improves consistency. Introducing our solution, which is a low-cost, compact, and universally compatible module that works to enhance current workflows and improve the clearance of fluid through vibration amongst other modalities. This is our team, involving some graduate student engineers and some clinician leaders and regulatory experts. And this is some of the key feedback here, 3 of which include the broad indications we're having for this, competitive vulnerability and regulatory gaps, and these are the ways we're mitigating them. And we're validating this path through FDA classification and clarification, and assessing what the buyers truly want. Our path to market currently has, or costs about $40,000 without overhead to bring it to a design lock and further phases of testing after that. And those are some of the key milestones that we have, including FDA submission. And I dream of a world where patients, physicians, and hospitals can worry less about surgical drain complications. Join me and let's engineer for flow.
I think I saw on one of the slides, and thank you for that. That was great. That there was a lot of use cases. You selected one to start with, which is great. But are any of the other use cases, do they allow you to skip the FDA approval? Maybe selective, plastic surgery or anything like that?
Certainly. So currently, surgical drains as a whole are classified as class 1. But some of the modalities that we're trying to use for enhancing the function can increase the risk of using the device. And so that's what we're hoping to get by a Q-sub or a P-sub to help clarify what that testing path will be and ensure safety.
Any other questions? Okay, thank you, Jordan. Okay, so now that we've gone through the first cohort, if you all want to scan that QR code, you can vote for your favorite as part of this group. Give you a couple minutes to pull out your phones and do that. Still see some phones out, so I'm gonna give another second. Okay, so I think we'll go ahead and advance the slides. And so now I will introduce Dr. Stephen Ecker, our Associate Dean for Innovation Entrepreneurship, who is going to share a bit about our strategy and updates. So let's welcome Dr. Ecker.
Thanks, Nicole. All right. Well, I'm just reflective that I was proud of the fact that I made associate professor and tenured at the University of Minnesota, and I didn't know where the dean's office was. So this is unapologetically our ads, our internal ads, sharing what we're doing, and I hope that they are better than ads. They're informative, and I hope that there's the ability to partner as well. All right. So who are we? You heard a little bit about it from Claudia. I would guess that the best way to know who we are the teams you just saw. So, but behind the scenes, we have awesome staff. We have Keegan and Nicole and Chris and all the associates, but there's also other folks. Suzette's also here. This is the team that makes it all happen. And most of the time, I love the fact that I'm just in the audience enjoying just like you. But I do want to talk about a couple of things. So as we're been doing this, we have the last couple of years been really being more deliberate about the ecosystem, which means not just the health innovations, but the health innovators, and that those two go together. And so just like we have wonderful faculty or advanced researchers bringing in new projects together, those are awesome learning environments for the health associates. And you've been seeing and hearing, for those that have been a part of this, how that grows, and we continue to do so. We are also deeply interested in startup acceleration. We do this all with partnerships, ATI, ICOR, anything we do with SPIR, the Health Supernova is coming up. These are all abilities for us to activate and partner with that. And I just want to offer that it's an open invitation for those that would like to partner, or you can still criticize us. We take feedback seriously if there's opportunities for us to be better. Here's some numbers, some amazing numbers that have been put in place. This is the Health Innovation Pathways. This was being run for many years as a part of the Texas Health Catalyst program. A lot of it was more of an administrative support, which is still important. But by elevating the health associates, the top healthy associates to our TAs, we are building a vertical stack with the innovations. And we have some exciting outcomes. A number of these are shown here. I just want to point out that if you sit down and work with any of these health associates, they are amazing. Our Longhorns are amazing. And if you're hiring, you should try to recruit them because they are in high demand. And our job is to empower them to be even better. All right. So the program itself, which are these projects oriented, we actually had a milestone in the last year where we actually could count and validate that over $100 million of follow-on funding had been received by the projects, with less than $2 million of seed capital being put in over the last decade. And that really reflects the whole ecosystem, and really does demonstrate that there's value created here. And hopefully in the next decade, it will continue to translate, just like you heard, Babson started in this program, and we have the second phase and third phase of these operating. It's exciting space. Okay, a couple things, save the date. We do have our date for the next Roundup Rodeo. It's December 10th. We don't yet have the domain, the topic yet, but they will be opened on August 3rd. I want to add one piece here. So 2.5 years ago, I came to Austin. Ruben was by far the most welcoming and amazing colleague and partner, and we wish him the best. But that's nice, but what's even better is something that he can hang up on his wall in Oregon. And if you haven't done so, there's a place for you to thank Ruben and put your little note at the back. And on your way out, I ask you to do so. And it's something that we would like to leave as a gift. Thank you, Ruben, for all you have done. And we hope that you can hang it up and showcase us while you're there. So thank you. Okay, so we have done one additional experiment with this Texas Health Catalyst call. So in January, I made a trek down all the way to Texas State and had a wonderful partner visit with Matt. And we brainstormed and said, well, why does this distance matter? And so we tried an experiment where we are including a Texas State innovators in this Texas Health Catalyst program. So with that, I want to introduce Matt. Some of you may remember Matt. He's proudly wearing his Longhorn pin. And he'll tell us a little bit about the work he's doing just down the road. Oh, you ready, Matt? Okay, thank you.
Thank you, Steve. Yeah, so while I was at UT, I think I remember the first Texas Health Catalyst event. And it's always been one of the events every year or twice a year, look forward to. And it's the one I always put on my calendar, make sure I can come. And mainly it's because of the people who are here today. Just a collaborative spirit, the can-do, the willing to lend a hand and help these innovators move things forward. So it's great to be here. For those who aren't familiar with Texas State, it's right down the road, I-35. If you got to the outlet malls, you went a little too far, just turn around. And actually, we have Star Park down there right by the outlet malls. But I just want to highlight a few things about Texas State before I give a little bit background about this collaboration and have Dave come talk to you. But Texas State is growing in pretty much every good way. We have now over 44,000 students, which just blew my mind. I think it's growing, Dave, like 10% a year almost, which is, yes, it's fun. Last year, we had over 183 million in research expenditures, which is a huge growth as well. Related to innovation, in the past 2 years, compared to the 2 years prior, our invention disclosures have tripled, patent applications doubled, and patents issued tripled, which is just a big testament to the support of leadership there. A couple very specific things I just want to mention in case you want to talk about other collaborations. Some very unique things Texas State has that I only knew about because my kids' actual field trip. So if you ever heard of the Meadows Center for Water and the Environment, glass boat tours, anyone raise their hand if they've heard of it or been on one? It's an amazing nationally, even internationally recognized water and environmental research center. Really cool. We also have the Freeman Ranch. Did anyone know about Freeman Ranch? No hands. A couple. 3,500 acre ranch right west, the west side of San Marcos, between that and Wimberley. There's a body farm there. All kinds of thanks, Weston. A friend described it just last week as Texas State is comfortable doing the uncomfortable. And I love that, especially when we're doing innovation and entrepreneurship. But Freeman Ranch is there. They do really cool stuff, rocket testing companies, drone technologies testing, but then agriculture, things like that. But also because we're here about healthcare and translational research, we also have the THRC, or the Translational Health Research Center. My colleague, super amazing colleague, Dr. Carolyn Chang is here if you want to talk to her. But they do amazing work around bringing together faculty, students, and community collaborators, which aligns with the Health Catalyst to drive innovative and interdisciplinary research forward. But as we're building out innovation and entrepreneurship programs at Texas State, we're calling kind of our university-wide initiative Bob Catalyst. We're the Bobcats. Catalyst. Yeah, I get some chuckles. I joked with administration when we were soliciting the idea, like, I think this is only something we could get away with in academia. But it is working. We're doing customer discovery training. We're doing proof of concept funding. And we also have some really fun additional collaborations moving forward. But while our programs currently are industry agnostic, we have seen a growth in healthcare related innovators on campus that want to move their ideas forward. And being a relatively small population of just a few innovators a year, doesn't make sense for us to stand up our own program like this to help move these ideas forward. So we talked to Steve. We're doing this experiment. I'm absolutely loving it. We had two of our innovators apply. One of them went through the whole full cycle, and you hear from him here. Dave Thompson, it's been a delight to work with, and I'm super proud of him and his team. And I'm excited to see this and see what would come of it. So Steve, Ruben, Nicole, the whole team, yeah, thanks for doing this. And I'm excited to see what happens first. So, and after spending, what, 18 years at UT and UT System, and now down as a Bobcat, I have to say, hook 'em, but also eat 'em up cats. So thank you.
All right, great. Keep building. Okay, so we have a couple more ads of the programs that are upcoming that you should be aware of. There's the Nucleate group. There's at least one Nucleate in the back. This is this wonderful program run by graduate students, for graduate students, but also for the community. So who in this room has heard about the Nucleate program? Okay. If you look around and you don't have your hand licked up, there's somebody around here that can probably tell you about it. So these are some save the dates. This is that it? Okay. So the last thing is that we're here to connect, make sure that you have the opportunity to reach out to us in person or through all of these mechanisms. And with that, your ads are over and we can actually resume programming. And I'll hand it back to Martin.
Thanks, Steve. And so it's my pleasure to get started with the second half of our presentations. I'm Martin Rotman, the Assistant Dean for Medical Innovation Entrepreneurship in the Dell Medical School's Office of Innovation Entrepreneurship. And for our second half of the pitches today, we have invited 4 additional judges, and I thank you very much for helping us out today. We've got Mike Boyle from Sempulse, we've got CJ Haynes-Dale from Altus Capital. We've got Arturo Pina from AP1 VC, and we've got Weston Waldo from Longhorn Ventures. And I appreciate you guys for spending some time here with us and listening to the presentations and giving some great questions and feedback to the innovators. Thank you very much. And then we're going to dive into the second group. The second group starts off with our guest speaker, Dr. Thompson from Texas State. I'm going to invite Elijah Ladak to come and introduce him.
Good afternoon. My name is Alia, and alongside my associates, Leah, Sophie, and Darson, we have been serving as health associates for the future of aging, sleepy, and passive. Our role this cycle has been to bridge the gap between technical innovation and clinical implementation by creating a commercialization strategy that focuses on passive monitoring to detect neurological deficits early. By tracking subtle changes in body composition, this technology has the power to be a low-cost and non-invasive way to be an early detection system for neurological deficits such as dementia and Alzheimer's. We have created a business model and refined it, as well as worked to integrate this technology into clear pathways to memory centers and nursing homes with the help of our mentors, Dr. Gopalakrishnan and Dr. Bertelsen. It is my pleasure to introduce the innovator behind it all, Dr. Thompson.
Well, thank you all for coming today. The title was suggested by Matt, actually, and his sense of humor shines through. I do, however, mean it. I like it because it's real. I think that sleep is the single most critical thing to study in aging. It's linked to dementia, it's linked to cognition, it's linked to weight gain, it's linked to every single health parameter of interest, including cancer. And the passive, I'm going to illustrate by way of a counterexample. If I ask this room how you want to monitor sleep, I think most of us would say throw an Apple Watch on it and call it done. But there's a problem with that approach. And among the current generation of the elderly, there's a resistance to technology. And among everyone, there's a little problem called battery life and remembering to charge things, remembering to wear them. You all, if you've had a sleep tracker, have forgotten to charge it the night before, right? Our motto is, if you don't have to wear it, you can't forget it. And in the aging population, this is pretty important. Our system relies on ballistocardiogram, which is a measure of the forces of blood accelerating through your body in response to your beating heart. It's an older technology, which is, we have had the fortune to just catch lightning in a bottle and use for new purposes. We're, to our knowledge, the first group to use it not just to detect heart rate and respiration, but to use it to do blood pressure, sleep staging, some daily behavior in children with autism. That's a different market. I'm not doing a disclosure today. And also estimating body composition, where we have a provisional patent. And this is the team. On the left are some folks from Kansas State University. I'm a Kansas native and a relatively recent Texas transplant. And then I've also got a collaborator, Carmen Westerberg, who is at Texas State, is bringing in some sleep and psychology expertise. And I just want to thank both my health associates, my mentors, and also the staff here for the dry runs, including Martin, because my proposal looks nothing like what it started with. They helped me to select a beachhead market, which is elder care. I do think this thing can work everywhere. I think it could work for people in this room. I think it could be relatively rich, and we have used it for children with autism. But we're going to focus today on elder care, on fall risk, and body fat estimation. And we've recently switched to a patent versus published architecture, and our competitive advantage mostly is just moving fast. In the next month, I get to convert my first patent, which is going to take my entire time. And then after that, we're going to try going into nursing homes and care facilities using my startup funding, among other sources. The goal is to develop a full sensor suite which works for multiple populations and disease etiologies. And the note here on the why now is just, we all know the nation's getting older. It's a time to start thinking about this and technologies which can help lessen the medical burden. Anyway, here's my contact information. Thank you for your time and attention. I'm actively seeking collaborators along with venture capitalists and other or potential licensors for IP, because we're just getting started. Oh, questions?
So how do you see this being deployed then? Is it built into a bed? Is it a mat that sits under a patient? Talk to me about, the practicality and what you see the price points to deliver this at.
Yeah, so there are some options. My favorite sensor is based on load cells. They're old force sensors that are relatively cheap, $30, $40 a piece, and then some electronics to capture what comes out of them. Those can be put into the frame of a bed and totally disjoint from any wires on the person. We also use some electromechanical films that can go under the mattress, usually a little sewing, and so again, no touch or no contact with the individual. As far as price point, for research grade stuff, I can fit a bed for less than $1,000. For deliverables, we can get lower than that. We're just going to drop channels and drop fidelity. So where do I see it being used? The first case, it looks like to me it would make sense to look in elder care facilities. So if you look at nursing homes, assisted care, assisted living centers, but eventually I'd like to put it in people's apartments and just out and about.
Yeah, that was basically that answered my question, is that there's obviously a giant population of the elderly that still lives at home. So
right.
Have you thought about licensing something like this to Tempur-Pedic or various, or the sleep numbers, or how can you incorporate this technology in something that's more commercially available, not just to nursing homes, medical facilities, but particularly to a regular consumer at their home?
So I think it's possible that I can't answer one part of that question due to an NDA. I'd have to check the calendar and the date on that. But yeah, I have talked with those companies. I do think it's quite possible that there could be a universe where these technologies are incorporated in there. Yes, and I'd like to do that.
Thank you very much. Thank you very much. And up next is, I'm going to invite Natalie Borrego and her team to join and introduce the next speaker.
Hello, everyone. My name is Natalie Borrego, and I am joined here by my fellow health associates, Kaden Becker and Aiden Chang. Today, getting tested for sexually transmitted infections, or STIs, often means waiting days for results. This creates gaps in care for over 1 million patients worldwide who acquire an STI every day. But what if that entire process could happen in just minutes for only $15? And that is the promise of LampDX. LampDX enables multi-STI testing within minutes using a cassette platform. So to better understand consumer needs, we as health associates collaborated with the Student Health Advisory Council at UT Austin's University Health Services Center to distribute a survey on student needs on STI perspectives. Now, this effort not only allowed us to have future prototype testing at UT Austin, but also other universities to gather and further clinical validation. We would like to thank our mentors, Doctors Hillary Graham, Kristen Mondi, and Kristen Badra. And without further ado, I would love to introduce Ms. Nicole Chauncey to come to the stage to tell you more about the future of diagnostics.
Hi, I'm Nicole. I'm a PhD student at College of Pharmacy at UT Austin, and today I'll present to you LampDX, which is make gold standard molecular diagnostics accessible to everyone anywhere for under $50. And let's see how we'll accomplish that. First of all, infectious disease diagnostics are broken in 3 fundamental ways. Results take days up to a week until we have a definite answer, and within that critical period, we don't necessarily have an answer, so disease can spread. At the same time, standard molecular approaches are highly expensive, ranging from $50 up to $150 per test, and there's not an affordable option for multi-pathogen detection, whereas cheap antigen tests can lack in sensitivity, but they're fast. So let's see where we're coming. Our innovation is LampDX, and it lies in its novel algorithm, which we're able to detect a specific set of genetic signatures that are exclusive in each organism across the entire tree of life. So this allows us to create high specific primers that do not co-react and allows high specificity and high sensitivity. And at the same time, as you can see, it's the start chamber cassette that we can use these highly specific primers to do multi-pathogen detection. And this can happen for $15 within 30 minutes without expensive PCR machines, without any lab for any pathogen. And how it works? It works pretty much like a COVID test. We can see that we have the platform, we collect the sample, we isolate the DNA, we load the sample in the cassette, we heat it, and we have the visual result instantly. So it doesn't need an expensive machine. So while LampDX can be applied to virtually any pathogen, we will focus as a first application to sexually transmitted infections. And as you can see from public results, we can see that there is a gonorrhea crisis and in Texas, and we can see that there is increase in tension from 2012 up to 2023 with 62,000 cases and pretty much similar high numbers for chlamydia. Our team is interdisciplinary, and we cover all the major pillars, led by Ilias Georgopoulos Soares at UT Austin at College of Pharmacy. And we have international collaborators with a wide range to access to a wide range of clinical samples. So what do we want from Texas Health Catalyst? We want to provide the initial seed so we can proceed with the LAMP validation, isolate the DNA, finalize the cassette design so we can have a market-ready product. So we're asking Texas Catalyst to bet on this platform. Thank you.
How much, thank you for that, that was great. How much of the cassette and like the manufacturing of this is like off the shelf materials, equipment versus like proprietary?
The main idea is that at first we targeted to doctors, but the main idea in the long term, we wanted to be at the shelf. But at first, we wanted to be something that clinicians can use very easily. Yeah.
I'll rephrase my question if you don't mind. The cassette itself, right? Is that something that the company has to manufacture or something that you buy from somebody else?
It's something that I probably will have to buy from somewhere else.
Got it. Thanks.
But I'm not 100% sure because I'm on the scientific team. I don't know about the on the algorithmic team.
No worries. Thank you.
Yeah.
All right. Thank you very much.
Thank you.
And then up next, I'm going to invite Isha Srinivasan to introduce the next team.
Have you ever struggled to stay awake? If so, you'll want to listen in. My name is Isha, and along with my fellow health associates, Anjali and Spencer, I've had the opportunity of working with an exceptional startup led by Dr. Ilya Pyatnitsky, Neuroware, along with Dr. Wong and Dr. Willie. As health associates, we've had the honor of working with Neuroware on their breakthrough wearable neuromodulation technology, both for the general consumer and for Parkinson's disorder symptoms. As our efforts this semester have gone forward, we've worked with Neuroware across efforts including presentation storytelling, business model development, and regulatory pathway analysis. All of this has culminated in the creation of a dual product roadmap to take both of our products forward, clearly from research to revenue. We're thankful for the guidance of our mentors, Dr. Ecker and Carrie Britton. And without further ado, I'd like to welcome Dr. Ilya Pyatnitsky. Thank you.
Thanks so much. Hey all, I'm Ilya, CEO and co-founder at Neuroware, and we're building the first wearable focus ultrasound for sleep and wake on demand. Quick show of hands, who had a poor sleep last night? Me too. I ended up taking melatonin pill. Over 1 billion people worldwide have sleep and wake disorders. Yeah, wearables can measure them, but targeted treatment don't exist. This is the gap that we are closing. Zoom in on one condition, Parkinson's disease. 350,000 Americans can't stay awake. They fall asleep mid-conversation, mid-meal, and sometimes while walking. The standard of care is stimulant pills. They don't work well. We can do better. We built Sleep Switch, a non-invasive wearable headset that uses focus ultrasound to reach deep brain circuits. It has 2 modes. Sleep mode stimulates before bed for faster onset and deeper rest. Wake mode stimulates each morning for vigilance, attention, and motivation. Our brainwave sensors validate in real time that we have hit the right spot. And this is not something theoretical. Our DARPA-funded platform has already been validated in 30 human volunteers with successful deep brain reach, significant sleep improvement, and high safety. And it's really easy to get this product. One clinic visit to calibrate using MRI, then 50-minute daily session at home guided by an app and real-time brainwave recording. We're building 2 products. Sleep Switch consumer launches over the counter in year 2. Sleep Switch RX follow FDA clearance and is designed for durable medical equipment coverage and remote monitoring built under existing CPT codes. The market is enormous. Global sleep and wake disorders over $100 billion. In the US alone, $20 billion. Our 7 years beachhead $1 billion, which include Parkinson, ADS, and plus only consumer. We start focus. The platform expands to every condition where sleep and wake circuits fail. We'll run our feasibility study in Parkinson patients in 2027, consumer launch 2028, pivotal trial for Sleep Switch RX 28 to 29, and FDA de novo approval and RX launch by 2031. We have a strong, well-balanced team with expertise in clinical trials, product development, business development, and entrepreneurship. We are preparing our seed raise, and the most valuable help today is an introduction to medtech investors, clinicians, and health systems exploring at-home neuromodulation. Sleep and wake are not luxuries. They're the foundation of everything: cognition, safety, quality of life. We built the first product that can treat both precisely, safely at home. We are NeuroWare. Thank you.
Sorry I missed this, but has a patent been filed or issued yet?
It's not, it's filed, all our technologies, including several patents, but not full patent yet, yeah. We're working through UT on this.
What's your exit strategy here?
Exit strategy, most likely, considering how industry works, medtech work, most likely M&A in 7-8 years to companies like Boston Scientific, Medtronic, Abbott.
Okay, thank you.
Okay, so I mean, we met before, obviously. Is this the same technology that you also are applying to?
Yeah, the same
epilepsy
technology.
and whatnot?
Right, and exactly emphasizing that this is platform tech that basically can be used for all major neurological conditions. Thank you.
You mentioned Parkinson. Did you get contact with Michael Fox Foundation to get funding also for this?
Yeah, we actually submitted just recently to them exactly this direction. Hopefully we'll get it. Thank you. Yes, there's a great program.
All right, thank you very much.
Thank you so much.
All right, so then the eighth group this afternoon is a special group. It is the winner of the team from Nexus, and if we can get the slides up. So, and the Nexus is one of our programs within the Health Innovation Pathway. And in the Health Innovation Pathway, we collaborate with the College of Pharmacy, running this program together with us, and the the Macomb School of Business. This year, we were even able to bring in the College of Engineering into the fold. The Nexus program brings graduate students from all of these different groups together, gives them University of Texas intellectual property, and asks them to go out and do customer discovery to identify what is going on, if this program, this innovation should go forward the way we think it should. The teams are asked to do 20 or so or more customer discovery interviews and validate the value proposition over and over and refine it over time. I'm very proud to introduce the winner of those 4 teams when they pitched their 10-minute pitch. And we then asked them to, as a reward, reduce that down to 180 seconds. The team here, represented by Doan Kim, is going to present what they did to identify what the real value proposition is behind prostatic bleeding device for benign prostatic hyperplasia, or HPV. Doan, please come on. It's all yours.
Thank you for introducing us, our special team. So benign prostatic hyperplasia is incredibly common, affecting about 50% of the men over 50 years old, creating this massive and growing need for effective treatment. The aquablation therapy has rapidly expanded in the market in response. So we see about 30-fold growth in the past 5 years, largely due to its ability to preserve their sexual function versus the current standard of care. Despite this momentum, there's a critical bottleneck, which is a post-operative care. Currently, we see about patients staying about 1 to 2 days inpatient due to surgery after the post-operative bleeding, and with no current dedicated monitoring tool, surgeons have to rely on their subjective judgment, often leading to longer hospital stays. Our device Prostasis is designed to close that gap. We're introducing the first real-time bleeding monitoring, and by giving clinicians that objective and continuous feedback, we aim to standardize the procedure and reduce the uncertainties of the procedure. Our team is uniquely positioned to solve this problem. We bring expertise together from the College of Pharmacy, Cockrell School of Engineering, and Dell Medical School, with our PI with representation of 5 major health organizations, including Bayer, Scott & White, and Dell Medicine. With this very strong foundation, we conducted total 22 interviews, and we interviewed spanning across urologists, patient advocates, and regulatory leaders, and all these insights helped us refine the value proposition for these stakeholders. So as you can see on the left, this is our old value proposition, where we focus more on the reduction of bleeding risk itself and an earlier discharge. But from 22 interviews, we learned that first things first, yet bleeding is important. It is only one of the several drivers for the overnight stay. So targeting bleeding alone would not be sufficient to fully shift the physician inertia. Another factor that we learned is that complication rate for the bleeding itself had reduced from 6 to 1% in the large volume centers. So that might mean that bleeding itself may not be as of a big pain point as versus what we thought in the earlier value proposition. However, we also did learn that there's huge opportunities. There is a large unmet need in the standardization and also a huge pain point in the overnight stay cost and then sexual dysfunction and complications. So with that, I want to introduce our final value proposition that we revised from the 22 interviews, is that our device aims to shift about 80% from patient population from inpatient to outpatient surgery, and also improve the overall procedure consistency. So compared to what is in the market right now, we propose about $3,000 cost saving per case, and also able to reduce the sexual dysfunction and also increase adoption for aquablation. Our next step would include more stakeholders to interview with payers and nurses, as well as mapping out the regulatory pathway, ultimately leading to our clinical validation to prove that our device is efficacious and also effective in reducing the perioperative cost. As I wrap up, I know we're a special team, so I wanted to wrap up with our key takeaway from the Nexus program is that growth really happens when you listen to your stakeholders, not defend your product, and be willing to uncover your product's weaknesses. Yeah, so with that, I'm gonna introduce bring my team member to answer any questions from the audiences. Thank you.
Hey, great presentation, and congratulations on winning the Nexus program and stuff too. I'm really curious, who do you feel like is one of your first customers that you think you'd be the most excited about to sell to?
Okay, so for our product, after talking with a lot of interviewers, we just find that actually, if you want to push our product to the market, the first one we have to let them buy our product is surgeons. So basically, we talked about the regulatory and insurance companies and the patient advocacy, but the people who decide if we want to buy is the surgeon. So at the first stage, we will try to connect with different medical centers and hospitals to try if you want to use our products.
All right, and thank you very much for your presentation. And as I ask all of you to take out your phones again and scan this QR code to vote for any of the 4 presentations that you heard in this second phase, I'm going to ask our judges here to join Praneet over there to deliberate and give us your votes. Give you a couple more seconds to scan that QR code. And then you've heard a few times now something along the health innovation pathway. The health innovation pathway was mentioned earlier by Steve. I mentioned it a few times as well. And I just want to dive into that a little bit deeper, because it's one of the 3 core pillars of the Office of Innovation and Entrepreneurship. We are trying to build, we are building the ecosystem in healthcare innovation. And by doing so, we are doing that through 3 distinct pillars. We are training, empowering the innovators, who are currently innovators or will be innovators in the future. We're giving them an ecosystem where they can take their innovations, their best ideas, turn them into investable ideas, and then bring them to places like this and other partners that Steve has shown earlier to move those ideas forward into high-value opportunities. In the health innovation pathway, we really try to be here as early as possible. You've seen our health associates on stage today. These are undergraduate students and first and second year master students in our medical school. We help them see innovators move forward in this program to get to a point where in their end of their medical school or in their undergrads overall, they can build and lead innovation teams. So that by the time that they reach their residency and join us on faculty and staff, they have an ability to understand what it takes for a good idea to become an investable idea. Similar to what you've heard earlier today in our Nexus team, really understanding what is truly the value proposition without changing the technology, truly understanding what's the value proposition to move an idea forward. Over the last 2 years, we have built various programs, including the Health Associates pathway, as well as Collaborate, like I mentioned earlier, around Nexus. But we've also created, through the academic exercises, we have created an enrichment elective through our Health Associates program. And currently, we are collaborating further in our quality innovation and quality improvement projects within the medical school. To bring a few highlights forward around the Nexus project. The Nexus project, as I mentioned, originates out of the pharmacy, School of Pharmacy, where we collaborate in the Dell Medical School and the Macomb School of Business, and now also the Cockrell School of Engineering, where we bring 4 teams forward. This year, we were able to also bring in our residents from the medical school. And first time this year, we were able to offer internships for some of the students to join startup companies here in Austin and even outside in the broader ecosystem. This slide was shown earlier. These are our metrics for our health innovation pathway. I want to highlight a few items on this pathway. First of all, we've trained now more than 200 health associate consultants. And we've given them more than 800 hours of bootcamp training to get them to help out other innovators and have impact at different institutions. And we've noticed that this really works because we see when some of our students join innovation teams, they stay with those innovation teams later on as well. In fact, over the last time that we were on stage here, we had 2 students who joined an innovation team full-time. Now we have 15 students from our Health Associates program who have been joining innovation teams and helping them move their ideas forward. I'm going to introduce you one team that has now joined us on stage as an alumni team. I'm going to ask Iris Rafferty to join us on stage. Iris is one of our health associates from the fall of 2024 and who has joined Dr. Kenneth Moisey in his project at the time and has now joined that team as a full-time member. So, Iris, please join.
Thank you. Hello, everyone. My name is Iris Rafferty. I'm a health associate and a third-year biomedical engineering major here at UT. I'm so excited to introduce Dr. Moise, who I had the pleasure of working with in the fall 2024 cycle of Texas Health Catalyst on the smartphone detection of fetal movements using AI project. To help, I helped conduct market research to better understand the need for improved fetal movement monitoring and tracking. After the cycle, I had the amazing opportunity to continue working with the team, where I first started out by helping with recruitment efforts, and I've now pivoted to helping with the app's development. It has been so meaningful to see how a clinical need has moved from research and market discovery to a real tool that will help directly impact patients. I've been so grateful to learn from Dr. Moise and his team, and I'm so excited for y'all to learn more about his work and hear about his experience with the Texas Health Catalyst. Please join me in welcoming Dr. Moise.
Thanks, Iris. So what I want to show you here in a very brief time is what we're doing in our project and how Texas Catalyst got us started. This is what you see here is an ultrasound of a fetus between the two red arrows, the fetal chest, and you can see the breathing movements. Along the top strip, you can actually see the audio recording and those spikes are going along with those fetal movements that are occurring in utero. This idea came to me 8 years ago. And the young lady on the left is my oldest granddaughter, is now 8 years old. And when she was in utero, I had my oldest daughter record some audio recordings, brought those with me to Austin, had them analyzed at the Texas Advanced Computing Center, and I was told there's something to this. So we began a pilot study. You see one of our patients on the right, where we did simultaneous recording with ultrasound, a smartphone audio recording, and then the patient's perception on a laptop. At the last year, at April 2025, we were lucky enough to receive $35,000 from the Texas Health Catalyst program, and we won the Pioneer Award at this very meeting some time ago. And what we were able to see, we've now done this in over 220 patients in our pilot. And if you look at our graph here, first on patient perception, we broke our movements into 3 types: gross fetal movement, breathing movements, and hiccups, and that's the patient perception you see in that graph. And when we applied our AI model to this, you can see we do so much better than the patient in detecting fetal movements, both gross, much better in detecting fetal breathing, and we can even detect fetal hiccups better than the mom does. So across the board, we're picking up fetal movements much better than the mother perceives those movements. We were able to get our first publication, just came out this month, in one of our major journals. It's read by 40,000 OBGYNs in this country. With the money from the Healthcare Catalyst, we were able to form 3 focus groups. 2 of those were a not-for-profit stillbirth group, so we talked to moms who'd had previous stillbirths, and with their input, we began the development of an app, which is about ready to roll out. And here you see some of the screenshots of what that app's going to look like. We had moms weigh in on the name for the app and came up with the name Womb Watch, and that'll be the name of the app as it gets rolled out. We were lucky enough just recently to be awarded from the UT Real Health AI pilot project, a $500,000 award, which started in April of this year and will go until September of next year. And that's going to allow us to go into the clinical arena and actually begin to use our product. So we plan to enroll 60 patients, 20 at each of 3 healthcare science centers, and split between 50% low risk and high risk in the 3rd trimester. And we plan to start enrollment in July of this year and hope to conclude in September of next year. Our ultimate goal will be to roll this out to a large population to seek FDA clearance first and collect data based on IRB approval from actual large volumes of patients. In our focus groups, we had a 100% adherence to wanting to participate in research when this actually goes live in a large population. We hope to analyze that data and create personalized profiles of fetal movement that would potentially predict stillbirth and then move up to a diagnostic app as a Category 3 FDA app. Our goal ultimately is to prevent stillbirth. It still occurs in 1 in 175 pregnancies in this country, and we really don't have a current means of preventing that, but we hope we can change that. Thanks for your attention today and your support. Thank you.
Thank you, Dr. Moyes. So we have one more alumni to present on their progress, and we'll have one of our former health associates also introduce Dr. Leanne Field. So I'll bring on stage Azmat Panda. He was from our class of fall of 2024 cycle as well. He is class of 2028, majoring in electrical and computer engineering. So please welcome Azmat to introduce the next alumni team. Thank you.
Hello, everyone. My name is Asmat Panda, and I was a member of the Texas Health Catalyst Associate Program in the fall 2024 cohort. And our role as Texas Health Catalyst Associates was to help our project team focus on their path to market, as well as refine their business model. To help accomplish this, we worked closely with expert mentors and underwent training through the Texas Health Catalyst program, where we learned how an innovative strategy can be turned into a support system that not only saves millions of dollars, but millions of lives as well. Now, flash forward a year and a half later, my experience as a health associate still remains a valuable skill that I use every single day, as it taught me valuable concepts such as learning more about business models, passive success, and value propositions, whereas important skills in a very entrepreneurial environment that I used to help evaluate businesses and ideas. As a health associate, I work closely with Dr. Leanne Field's team on closing adult and prenatal immunization gaps. Our team had a successful proof of concept and was looking to close the gap and expand the CDC's code list. And now, after receiving funding, I'll hand the mic off to Dr. Leanne Field, who will introduce more about their clinical and innovative support system.
How do you advance the... Well, good afternoon. This is, you're coming into the middle of the movie, the VACOP Clinical Decision Support movie, and it's a public health informatics problem. And we were really excited about where we are today. So this is a look at our large team, and I want to point out one of the key persons on the team is Dr. Vincent Fonseca, who's board certified in clinical informatics, preventive medicine, and lifestyle medicine. So the opportunity is chronic diseases lead the cause of death, and they're the leading drivers of healthcare costs in the US, $4.5 trillion per year. 60% of adults have at least one chronic disease, and thus fully vaccinating these high-risk adults against vaccine-preventable diseases can keep them healthy and drive down healthcare costs. The problem is that healthcare providers often have a difficulty in their clinics identifying which high-risk adult patients need vaccines. This is because CDC's vaccines rules are now very complicated. You have 13 pages of notes for specialized situations, and the vaccine forecasts for the high-risk patients are not automated. Forecasts are based on the patient's age and previous vaccine only. So that means providers must manually look up which vaccines to give for patients that have chronic diseases. Our solution was the creation of the VACOP, or Vaccine Optimization CDS system. This work was funded for 3 years by Blue Cross Blue Shield of Texas, and we had a successful proof of concept at People's Community Clinic here in Austin. This CDS system was 100% accurate at delivering automated vaccine forecasts based on each patient's unique underlying medical conditions and contraindications directly into the clinic's EHR via public HIEs. How did we do this? We expanded CDC's medical code list from 104 total SNOMED CT codes only to 8,000 medical codes for 5 adult vaccines. Our code list identified 100% of patients at PCC with chronic conditions who needed vaccines, compared to CDC's code list that identified only 18% of patients. So the problem has been solved. Now we have to implement optimized vaccine forecasts based on our UT code set and aligned with ACIP guidelines, enable providers to quickly identify high-risk patients who did and did not need vaccines, and both of those are important. So we were very fortunate to receive a Texas Health Catalyst Innovation Grant on March 2025, and we had 2 goals. We started with 5 vaccines. We wanted to complete the medical codes list for all adult vaccines, both indications and contraindications, and we wanted to design a more user-friendly prototype display to show the optimized vaccine forecast. And then we still have yet to ask clinic providers and pharmacists to evaluate the displays. So we've nearly completed both our goals. So as far as the codes, we've now compiled an additional 6,980 new medical codes that are medical indications and contraindications to vaccinate across CDC's 64 unique observation codes. So our final code set, when we put it together with our original 5, will contain more than 15,000 medical codes. And it will include all 16 vaccines in CDC's recommended adult immunization schedule shown here. We also have finished the design of user-friendly displays, and this is just an example of one. And now we're ready to recruit some providers. Maybe there's someone here who would like to help us evaluate. And we will have one of 2 choices for providers, and they can vote on which one they think is better and why. And we've been very gratified to have some potential commercialization possibilities. One of our back-off partners is interested in licensing the complete UT code set. And we have a leading global pharmaceutical organization with a strong track record in vaccine R&D who has a strong interest in a potential collaboration. The scope would include validation of the medical codes, licensing, and annual updates. The research proposal I'm writing now will be hopefully submitted in the next few weeks, and we'll have talks about defining a viable path forward. And I've been very pleased to work with the Discovery to Innovation Office to learn about IP, how we're going to protect our UT code list, our optimized vaccine displays, and about potential licensing agreements. So the team that UT Austin has in place is just fantastic. So I thank Agapito and others who have come alongside us. So thank you very much.
Thank you, Leanne. All right, so now we're at this final stage. It's going to close things out. Today we heard some from amazing teams. The quality of the ideas, the clarity of their purpose, and their commitment to impact is incredible and really truly reflects the strength of this Texas Health community, Texas Health Catalyst community, which includes all of them. That was my mic drop. I don't know what. Oh, okay. So thank you to you all. But before I close, I just want to take a brief moment to sort of make a personal note. Many of you know now, all of you know, that I'm transitioning out of my role to this new professional challenge. It has been a privilege to work alongside all of you over the last 10 years. Matt Winkler is sitting in this front seat here, and Matt interviewed me for my role here, and we took a drive to his orchard, peach orchard, and we had some wonderful peaches. Austin won my heart after that interview, and Matt has continued to be an incredible mentor. And he's introduced me to some of the best Mexican places that are hole in the walls across Austin. To my team, Suzette, Nicole, Keegan, Chris, Martin, Steve, I've learned so much from you. Thank you for supporting me over the last 10 years. I'm not going to be falling off the earth, although Oregon seems like it's close. But no, seriously, I hope I can keep in touch with all of you. I will miss all of you. So please stay in touch. And thank you for being here, and I hope you can join us for the reception upstairs. That technically starts at 4, but I think we can make our way out there. So thank you again for being here. Thanks.
Oh, much better than it was here. Yeah, it was,